Hi, I'm Dr. Jeff Brown, board-certified internal medicine physician with a special interest in treating arthritis and other musculoskeletal conditions by ultrasound-guided interventions. I'm also the founder of the Joint Pain Solution Center of Fort Lauderdale. So our topic today is closing the osteoarthritis treatment gap by understanding the therapeutic window of early intervention. So this is really a perspective for primary care physicians on rethinking osteoarthritis as a biologically active disease and taking advantage of the early window of opportunity when intervention matters the most. Now, this topic is near and dear to my heart, both personally and professionally, because every day in our clinic we see patients who come in and they're seeking help because of their osteoarthritic related knee pain or hip pain or shoulder pain. But often by the time they see us, they're already bone on bone or end stage OA. So this talk is about what can we do to make a difference? How can we intervene early when the joint is still biologically active? So let's get started. So let's start out by rethinking about osteoarthritis and maybe even reframing it. Osteoarthritis is not simply a wear and tear disease process. And I know during my training, we were taught that osteoarthritis is simply a wear and tear process, much like the tread on a tire. As over time, as a person gets older and through multiple injuries over one's lifetime, that cartilage wears down just like the tread on a tire. And there was not a whole lot that could be done about it, as this was mostly a mechanical process. So for decades, we kind of viewed this, and certainly healthcare providers viewed osteoarthritis as a degenerative wear and tear process that really left not many options, and we treated patients symptomatically for their pain, but we never thought about intervening in the disease process because we didn't know about the different options. But things have really changed because today we know that the wear and tear model for osteoarthritis is completely incomplete. Certainly it plays a role. There is a mechanical role that is played over time, but that is not the complete story. So let's look at some more details about what's involved really in osteoarthritis. So osteoarthritis is actually a very complex biologically active disease process, which involves chronic low-grade inflammation within the joint itself, synovial membrane activation, cytokine inflammatory mediator release, progressive cartilage degeneration, subchondral bone remodeling, meniscal and ligamental degradation, and even altered joint biomechanics. So as you can see, there are many elements involved in osteoarthritis. It is not simply the mechanical forces wearing down the cartilage. Throughout the disease evolution of osteoarthritis, there's going to be low-grade inflammation. This low-grade inflammation could be systemically driven from obesity, a bad diet, poor sleep. There's even synovial membrane activation. Think about the synovial membrane of certain joints as the gatekeepers. The synovial membrane allows certain nutrients to come into the joint because the joint itself really doesn't have its own blood supply. It would be impractical for blood vessels to run in and out joints because of the mechanical forces coming onto the joint. So the synovial membrane plays a really important part in allowing nutrients to come into the joint, allowing waste products to exit the joint. It also controls what immune cells are allowed to come into the joint. And obviously, if the synovial membrane is dysfunctioning in such a way, it could allow inflammatory immune cells to come in inappropriately and to drive the process of osteoarthritis. Cytokine inflammation, we'll talk more about that throughout this talk, but there are many, many levels to osteoarthritis, and that's why this is much more than just wear and tear. This is a complex, biologically active disease process. So let's go a little bit further. So let's take a moment to appreciate the scope of the problem of osteoarthritis and also to appreciate the scope of the treatment gap that exists in the treatment of osteoarthritis in the US. So approximately 32.5 million Americans have been diagnosed with osteoarthritis in the US today. Now, out of the 32.5 million Americans with this diagnosis, 26 million or 80%, and this is really key to understand, 26 million, 80% of these patients have the diagnosis of mild to moderate osteoarthritis. They have not yet progressed to severe or end-stage bone-on-bone osteoarthritis. So 80% of patients who have the diagnosis of osteoarthritis have mild to moderate disease. Now, every year, 2.3 million patients with osteoarthritis go on to require hip replacement surgery, knee replacement surgery, and shoulder replacements. But guess what? We don't do these surgeries, we don't do these procedures on patients with osteoarthritis who have mild to moderate disease. It's not indicated. So we only do replacement joint surgeries on patients who have already progressed to severe end-stage disease. So this is really important to note that 80% of patients with osteoarthritis have mild to moderate disease. Now, here's the catcher. Mild to moderate disease will progress to severe end-stage osteoarthritis over the average time span of 10 to 15 years. So if nothing is done, if nothing is intervened upon, the natural history of osteoarthritis is to go from mild disease to end-stage disease for most people. Everybody's different, of course, over the course of 15 years. And so we have millions of patients sitting every year in the US, sitting, unfortunately, relatively idle, progressing from mild osteoarthritis to severe disease. So let's get a better appreciation of the typical disease progression and how it looks. So the very diagnosis or definition of mild disease, we grade it on different grading scales. There's a stage system, there's a grade system. So we'll use the grade system here. Grade 1 to 2 is considered mild osteoarthritis. So this is very mild. Most patients may not have any symptoms when you do an x-ray. You probably won't see much in the way of joint space narrowing. You can see some osteophyte formation of bone spurs, but patients may or may not have any significant pain related to their knees or shoulders or hips. But what do we do for patients like this in grade 1 to 2 mild osteoarthritis? We give them NSAIDs. So we do ibuprofen, we do naproxen, we do anti-inflammatories essentially. Often we'll also recommend a physical therapy regimen, but as you can see, based on how we're treating these patients, we're simply treating their pain. We're not focusing necessarily on intervening in the disease process itself. And so if we're only treating the pain and if we're not intervening, these patients will invariably progress to stage 3 or early moderate osteoarthritis. And if you were to do an x-ray here, you're going to start to see some joint space narrowing. You may even start to appreciate some early fissures in the cartilage, and so there's definitely some degree of cartilage loss here. Patients will likely start to become symptomatic, particularly after physical exertion. And so how are we treating these patients? Are we intervening or are we simply treating their symptoms? So at this point, often we'll consider steroid injections, we're giving hyaluronic acid injections, and we're repeating injections. Now, these injections certainly are helpful. They kind of put out the fire, so to speak, but they do not necessarily change, and they certainly don't have any major impact on the disease progression and the natural history of osteoarthritis. So if nothing is done, unfortunately, these patients will progress to progressive moderate osteoarthritis, which is a later form of grade 3 OA. And what do we do here? We do more medications. We may put the patient on Celebrex or Mobic or even prednisone, right? We may give more injections. Unfortunately, many of these patients will have to limit their activities. And as you know, that's devastating because motion is lotion for joints. And so when patients start moving less, the disease of osteoarthritis actually progresses. It doesn't get better. It actually gets worse. So patients progressing. And at this point, many patients will end up at stage or grade 4 severe osteoarthritis. At this point, of course, this is bone on bone. Most of the cartilage has been lost. This is tough because at this point, the joint is far less biologically active and biologically responsive. And what do we do for these patients? We refer to orthopedics, and we refer for consideration of joint replacements. So the problem is that many of our interventions are primarily directed at symptom control rather than influencing the underlying biological environment of the joint. And that's what this discussion is all about. How can we move away from simply symptom control treatment of OA to having an impact, having an influence over the biological environment of the joint while it is still biologically active and biologically responsive? And of course, this time period is in the frame of mild to moderate osteoarthritis. So let's go further. So let's focus a little bit more on this therapeutic window of opportunity. So as alluded to in the previous slides, in the earliest stages of osteoarthritis and mild to moderate disease is the time to make a difference. And so this is the time period of a therapeutic window of opportunity. It occurs, of course, in the earlier stages when the joint itself is still considered biologically active and biologically responsive to smart interventions. And that's what this talk is all about. What can we do early on to impact and to influence the natural disease of osteoarthritis versus simply treating with pain medications? So during this time period of mild to moderate osteoarthritis, there is still viable cartilage. As I mentioned before, in stage 1 through stage 3 osteoarthritis, there may be some loss of cartilage. There may be some fissures within the cartilage, but there is still plenty of viable cartilage left. Additionally, the chondrocytes, very cells that make the hyaline cartilage that coats the ends of our bones in certain joints, those chondrocytes are still alive and well. When there's chondrocytic death, essentially that is equivalent to joint death. That would be stage 4 osteoarthritis. So in stages or mild to moderate disease, the chondrocytes are thankfully alive and well. Synovial tissues remain active. And as we talked about before, the synovial membrane acts as a gatekeeper, allowing certain good things into the joint and blocking bad things from getting into the joint. So you certainly want responsive synovial membrane tissue, and you want it to be active. Inflammatory signaling can be modulated. And so the chronic low-grade inflammation that we refer to that happens, that we know is certainly happening in osteoarthritis, that can be modulated. And we'll talk about how the body goes about modulating that. There is certainly some structural deterioration in mild to moderate disease. There's some osteophyte formation, bone spur formation, but none of the structural deterioration is considered irreversible in mild to moderate disease. So it's not yet too late. Now, once bone-on-bone arthritis develops in severe stage 4 osteoarthritis, the opportunity to biologically influence the joint is greatly diminished. At that point, you're looking at mostly a mechanical process. The biology at that point is considered relatively failed. Thus, the time period, as we've alluded to intervene is during mild to moderate osteoarthritis. This is when biological interventions, smart biological interventions, can have the greatest potential impact. Now let's talk about the mechanism because we've been referring to smart interventions that can make a difference in the course, the natural history of osteoarthritis. So why orthobiologics make biological sense? So orthobiologics such as platelet-rich plasma or PRP are not simply just another injection to control pain. So orthobiologics such as PRP are much, much more than that. So PRP is particularly helpful in making an impact on the natural disease process of osteoarthritis because PRP, once you concentrate the platelets, these platelets are filled with wonderful growth factors, anti-inflammatory cytokines, chemokines, and even extracellular vesicles. Growth factors such as platelet-derived growth factor, which is one of the major foremins that the body uses when there's any injury of a vessel, of a tendon, ligament, or certainly cartilage. So PDGF, platelet-derived growth factor, shows up and it tells cells how to proliferate, how to divide, how to multiply. It even stimulates laying down of vessels through vasogenesis. PGF beta, for example, can turn down inflammation inside of a joint to allow the joint to go from a more catabolic state to an anabolic state. VEGG is very involved in angiogenesis. So growth factors are just fabulous. They're the body's repair mechanism. I would say platelets, which are filled with these growth factors, are only second to stem cells as far as healing cells in the body. What else is inside PRP? Anti-inflammatory cytokines. So interleukin-1 receptor antagonist. So this is a anti-inflammatory cytokine that is found inside of PRP. So when you do a PRP injection, you're introducing IL-1RA into the joint space, and literally that is turning off the major inflammatory driven process inside of that joint. So these anti-inflammatory cytokines are fantastic. And science is now revealing that the anti-inflammatory cytokines found in PRP may be just as impactful, if not more impactful, than the growth factors. So we have two fantastic biological mechanisms of how PRP and orthobiologics can have an impact on the course, the natural course of osteoarthritis. And then there are chemokines such as SDF1. And so this particular chemokine acts as a GPS protein molecule, as it were. It literally calls in local mesenchymal stem cells to come to the site of injury. And in this case, of course, we're talking about cartilage. And these stem cells, as we well know, they have the capability of becoming bone cells, tendon cells, even cartilage cells. So chemokines, which are found in PRP, will recruit local mesenchymal stem cells. So although PRP injections themselves are not giving stem cells, they are recruiting local stem cells which already exist inside your body. The average human body will have anywhere from 10 million to several billion mesenchymal stem cells. And then there's extracellular vesicles. So of course, you guys have probably heard about exosomes. I mean, this is the biggest rage right now. But the exosomes which are found in PRP are natural. And see, these are not exosomes manufactured or taken from outside of a patient's body. These exosomes exist already in the patient's bloodstream, and they're concentrated when you prepare the PRP. Exosomes are molecules which are lipid bound membranes, and they're also filled with growth factors, anti-inflammatory cytokines, and chemokines. All of these elements of PRP have been documented and shown to have an impact on the joint space itself, can certainly modulate the natural history of mild to moderate osteoarthritis. So what do they do exactly? They reduce pro-inflammatory signaling, they improve synovial membrane function, they support cartilage cell activity. They improve host repair mechanisms within the joint itself, and they even potentially slow degeneration of osteoarthritis progression. So we've been talking about what can we do in the early stages of osteoarthritis to have an impact on the natural history. How can we slow this process? How can we modulate this process so that 32.5 million Americans don't invariably go from mild disease to severe disease requiring joint replacement over a 10 to 15 year course. So it's important to note, though, PRP will not regrow a new knee. It doesn't work like that. Rather, it attempts to create a more favorable biological environment within the diseased joint where natural healing can occur. Okay, so let's take a look at the evidence. Hopefully you're still with me. So what does the literature say about PRP in the treatment of osteoarthritis and in the treatment of knee osteoarthritis in particular? Thankfully, over the last several years, there have been many well-done, high-quality studies testing and looking at PRP and trying to assess, does it really work? Does it have a lasting impact on osteoarthritis? There was a major meta-analysis in 2023 in the American Journal Sports Medicine comparing PRP to hyaluronic acid in the treatment of knee osteoarthritis. PRP, the findings showed a greater improvement in pain and function versus hyaluronic acid, often with the improved function and reduced pain lasting greater than 12 months. A systematic review in 2023 in the Journal of Orthopedic Surgery showed PRP significantly improved pain, function, and patient-reported outcomes versus placebo and conservative care. A European Society on Sports Traumatology consensus statement showed PRP is appropriate for selected patients with mild to moderate knee osteoarthritis and most effective before end-stage disease. A clinical practice guideline in the management of osteoarthritis in 2021 also showed that PRP may reduce and improve function of knee osteoarthritis. So this is just a very small sample of the many studies that have shown the benefit of PRP and similar orthobiologics in having an impact on the natural history of this disease. But there's no question that the results of many of these studies over the last 10 to 15 years have been mixed. And we'll talk a little bit more about why that might be in the next slide. So let's now try to address some of the reasons why studies on PRP and other orthobiologics may appear mixed in the literature. One of the main reasons for this is that PRP is not one thing. PRP is not a standardized drug. You cannot pick it up off the shelf in a vial. This is a biological product, right? So this is something that's coming, that's made from the whole blood of each patient. So by definition, because it's coming from a different patient every time, PRP is not standardized. It's not one thing. It's coming from a different person every time. And so if we really think about it, there are about 6 biological variables that might explain some of the variability in the study outcomes that we see around PRP studies. So the first one is PRP is not one thing. And so when studies refer to having given PRP or studying the effects of patients once receiving PRP, the question is what type of PRP was given? Was it leukocyte-rich PRP? Was it leukocyte-poor PRP? Was the PRP RBC contaminated? What was the volume? And so unfortunately, many studies being compared in the past didn't really demonstrate exactly what type of PRP were they using in the study criteria. And so thankfully, there are new systems coming out, the DEPA classification system in particular, where it attempts to quantify the type of PRP and classify the type of PRP so that when you're Doing a study, you're able to compare apples to apples and not apples to oranges, as it were. Then there's the dose. And so when studies note that a patient received a PRP injection, the question is, what was the dose, right? And so most studies show that an appropriate dose of PRP is on average 5 to 7 times the whole blood concentration of platelets. And if you're looking at a study and you don't know, it's not clear exactly what doses of PRP are being compared, of course, this could lead to variability in the results. And then there's the trigger. What is the necessary dose of PRP to trigger that biological response that we're talking about? Most modern studies now show that for a PRP injection to be effective in osteoarthritis, that you need a minimum of 5 billion platelets to be injected into that joint. And unfortunately, many studies do not clarify if the PRP injections reached this threshold. Studies are now showing that even higher doses of PRP are probably more effective. So we're talking in the range of 7 billion platelets to 10 billion platelets are required to reach that biological threshold to make a difference. And then, of course, there's spin preparations and spin protocols, because when you take a patient's whole blood and you're preparing the PRP, depending on your type of device that you're using to concentrate the platelets, it will spin the whole blood once or twice. It may spin it for 5 minutes, 15 minutes, 20 minutes. So when you're comparing studies, the spin protocol should be close. If not, again, you're comparing apples to oranges and not apples to apples. And, leukocyte content, we referred to this already, makes a big difference, because studies now pretty much show that leukocyte-poor PRP is best for the treatment of osteoarthritis, as contaminated PRP with RBCs can actually be detrimental for osteoarthritis, as the RBCs can damage the chondrocytes directly, and they can promote longer lasting inflammation. And that's just the opposite of what we want to do, because we know with osteoarthritis, chronic smoldering inflammation is one of the main culprits. Okay. And then when you look at the patients in these studies, because giving a PRP injection to a 21-year-old, as you might imagine, is different from giving a PRP injection to an 80-year-old. Given a PRP injection to someone who's healthy and fit and thin, it's going to be different from giving an injection of PRP to someone who may suffer from being overweight. As we know, the larger the body mass, the blood may be generally more inflamed. And if you're making PRP from a patient's whole blood and their blood is already inflamed, what effect is that having on the PRP, and what effect is that having on the knee that you're trying to improve? So the question isn't whether PRP works. It's better a question of what kind of PRP, at what dose, prepared how, injected into which joint, and at what stage of osteoarthritis. As we wrap up this talk, I want to leave you with a useful analogy. I want you to start to think about osteoarthritis like you think about cardiovascular risk, right? As providers, we do not wait until our patients develop end-stage coronary artery disease before addressing that patient's cardiovascular risk factors. Likewise, we should not think about osteoarthritis solely as a condition to manage symptomatically until the patient requires surgery. And certainly we shouldn't do this now that we know there are many options available to have an impact on the natural course and the natural history of this disease. Instead, mild to moderate osteoarthritis represents a stage of disease where biological interventions have the greatest opportunity to influence the trajectory of joint health away from worsening pain, functional decline, advanced OA, and eventually the need for orthopedic referral. So here's the big question for primary care. Every year, more than 2 million Americans undergo joint replacement surgery. And as we've learned throughout this discussion today, most of these patients spend years, 10 to 15 years, in primary care, progressing from mild arthritis to severe arthritis. And what do we do for them? Largely, we treat their pain, we mask their pain, but we're not intervening in the natural course, the natural history of osteoarthritis. So the question isn't whether every patient with OA should receive orthobiologic treatment. It's whether some patients during the biological active stages of OA deserve access to therapies aimed at influencing the disease environment rather than merely managing the symptoms until surgery becomes inevitable. PRP and other orthobiologics should be viewed as early intervention options within the continuum of arthritis care rather than an alternative to surgery or a replacement for standard medical management. Lastly, let's help close the osteoarthritis treatment gap by intervening early in mild to moderate OA by reducing inflammation, supporting cartilage health, improving joint environment, and even slowing the progression of OA. Because we know, as the diagram to the right shows, if we don't do that, we know where our patients are heading. It is not a fun place. It is not a fun time. It's very painful. There's a lot of unnecessary suffering. So hopefully you've enjoyed this discussion today. This topic is near and dear to my heart, not just because I do this on a daily basis, but this is somewhere where we can improve as providers. And prior to practicing orthobiologic interventional medicine, I didn't know a lot of this stuff. So hopefully what I've shared today to primary care physicians and other people, other providers who take care of patients with OA, hopefully this will be helpful in your practice and helpful for your patients. So until we meet again, take care. Have a great day.